work it out. So we talk about the anatomy and physiology. We will go through a lot of it. So this is just an introduction part of the anatomical terms. You will see a term that I don't use very much except that it's in the test bank, topographic anatomy, topographical. Top means on top and then graph. So essentially it's telling you on top of the body, planes that are on top of the body. And this is what it's talking about with these anatomical terms. When you talk about topographic anatomy, one thing that it does is it gives you accurate patient assessment of locating organs and systems and places, and it makes the care of the patients consistent because you're all using medical terms. When you say the chest, the injuries on the chest, the first thing you probably would like, where on the chest? So we use these directional terms to precisely locate where you're going to place. Like if I was going to do what's called a needle decompression, which is treatment for a tension pneumothorax, which is life-threatening. A tension pneumothorax is what you would call a collapsed lung. I would place a very large needle in the patient's chest, mid-clavicular, in the between the second and third intercostal space. So when I hear that, or when you say place this needle here, I know exactly where to place it. The other thing is, like another directional term, is put a chest tube in. Chest tube goes in the mid-axillary between the fifth and sixth intercostal space. The intercostal space being between the ribs. So see how it sort of gives you exact directional terms, exact sort of terms, where to put stuff. It describes the anatomy. When you talk about the anatomical position, this is only really important when you're doing testing things because it puts the thumbs at a different location. But the anatomical position is facing forward with the thumbs to the outside, like this, in the lateral being the outside lateral. So the anatomical position facing forward with the thumbs rotated outward. And that, if you don't use that, if the patient's not in the anatomical position, when you describe the location of a bone or an artery, you turn the thumbs in, they're not in the right spot, right? So you have to make sure that you're using the right anatomical position. So when we look at this guy here, it breaks the body down into different sections. You have the head, the cranium of the face, and we will break this down. We'll go into this more detail in a little while. You have the torso, which is the thorax and the abdomen. The thorax begins at the supraclavicular notch. Supra means above. So this notch right here, that's very good for self-defense. And then the thorax ends at the plane of the diaphragm, so just right under your ribs here. This would be the thorax. Your abdomen begins at the plane of the diaphragm to the pelvic region, to the suprapubic region, right below the belly button. And then you have your pelvis, where most boys are supposed to wear their pants up on their hips or their pelvic girdle, right? Then it breaks down into the lower extremities, where you have the thigh, knee, the leg, ankle, and feet. Then the upper extremities, the shoulder, the humerus, and then the forearm. One thing to note, in the leg has two bones in it, and the arm, what's considered the arm, has one bone. The arm is considered right here. The humerus is what's considered the arm. This is considered the forearm. So when someone falls and they break their arm, most of the time they have what's called a radius ulna fracture. They break their forearm, but we just call the whole thing the arm. So it's simplistic, but when you break it down into medical terms, this would be the forearm, not the arm. The arm is where the humerus. So we look at that, then we look at these anatomical planes in more directional terms. And we look at this guy again, and the one line that's very important that we start with, we have to have a baseline. You hear that term over and over, we have a baseline. Our baseline in anatomical terms is the midline. The midline is a invisible line that goes down the middle of the body. So if you were to split the body in perfect half, the midline is that plane that goes down the middle of the body. Everything that's in reference, everything references the midline. So the middle of the body. You have medial, which is a term that means towards the midline. So medial means towards the midline. See how that references the midline? So you have to understand what the medial means, you have to understand midline, correct? See how they sort of build on top of each other? So you have the midline, which is the invisible line that separates the center of the body in two halves. Medial means towards the midline. Now these will make a lot more sense as we start using them over and over. All right? Your job now is just to memorize just the basic definition. Lateral, most everybody understands what lateral is. That's to the side. So lats, right? Lateral to the side. The other term that gets a little confusing, but not too bad, and we use these terms all the time. All these directional terms, we use them all the time. So distal and proximal, these are used as far as the extremities are concerned. Where you would use that is like in a distal pulse or a distal injury. Distal means away from the trunk or away from the injury. Depends on what you're talking about. So distal, away from the trunk or away from the injury. Proximal means towards the trunk. So distal, away from the trunk. Proximal, towards the trunk. You have distal and proximal pulse points, which we'll learn quite a few of the different pulse points as well. The other line can y'all see this white line that's right here? Mm-hmm. That's mid-clavicular line. That's like the midline, but mid-clavicular. Clavicular references what bone? Clavicle. It's in the middle of the clavicle. And then you have right and left. And it's always the patient's right or left. It's never your right or left. So the midline, directly in the middle of the body. Medial, towards the midline. Lateral, towards the side. Distal, away from the trunk. Proximal, towards the trunk. And then the patient's left or right. Is everybody good with those terms? I mean, it'll take a while for you to memorize them, but is there any confusion there? Any questions on those terms? Okay. The other terms that we use are telling us what region of the body. So we saying here, anterior is the front of the body. So when I say the anterior aspect of the thorax, I'm telling you it's on the front. Posterior means the back. So anterior front, posterior back. Dorsal, you will see this term. I don't really use it in posterior, but that's what it means. Dorsal means back. It's like the dorsal fin of the shark, it's on its back. You have a dorsal pedal pulse on the top of your foot. So dorsal we use quite common as well. I don't use this ventral very often. I use more anterior. It's easier to say. Then the other two directional terms is superior, means towards the head, inferior towards the feet. So you have superior towards the head, inferior towards the feet, posterior, the back, anterior gives reference to the front. What's on the front? Questions? Very good. Then when we look at this diagram, we see the diaphragm, this outline here showing you where the diaphragm is, because that's the what border?
The rib cage border.
Starts with an S.
Superior.
Superior border of the abdomen. See how that works out? Isn't that cool? I planned it that way. Superior border of the abdomen is the diaphragm. Then you have four quadrants of the diaphragm. You have the right upper, left upper quadrant, left lower, and right lower. And you notice here that the dividing line of the lower quadrants is the belly button. So when we do our patient assessment and you're palpating all four quadrants of the abdomen, you need to make sure that you're palpating below the belly button. If you don't get below the belly button, you're only, that's a new term for you, sorry. Palpating, to palpate means to touch. Let me try to spell it for you. E-A-L-P.
It's all in definitions.
Okay. So palpate to touch. So when you palpate for all four quadrants of the abdomen, you're palpating below the belly button. Very important as far as to make sure that you are covering all the spaces. Then two other terms, supine, which means on their back. So this tells you more, like if you're trying to describe, see how the patient is found. Like you go into the room and the patient's found supine, that tells you they're on their back. Prone is on their belly. So supine on the back, prone on the belly. Pretty easy to remember. Just takes time, right? I mean, we're just getting cranked up. So all these terms, we don't get going with them. Then, especially in CPR, we'll talk about this recovery position a lot. This happens to be it's called the recovery position or the lateral recumbent position. If you were to document this exactly, what lateral recumbent position is this patient in? Left, right. So it would be left. She is on her left lateral recumbent. Means she's on her left side. If you just say, I'm putting the patient in a recovery position without giving a side, they don't know which side it is. It's got to be left or right. That'd leave doubt in somebody's mind. Did you roll them on the right side or their left side? So we use the recovery position for an unconscious breathing patient in case they have in case they start to vomit. That way they don't aspirate on the vomit. Don't go down their throat. So the recovery position, very important. Again, we'll bring that back up into in CPR. Another term that we use is a Fowler's position. You won't use this very much. This just means that the patient's up at a 45-degree angle. It's more of a documenting thing that we won't really do. But remember that a Fowler's position, that's a 45-degree angle. And then another one, a Fowler's position is at a 45-degree angle. So, that was funny. So the Siri, I didn't get that. You don't get a lot of stuff, Siri. So, this other one, there's some new studies on this. It's called the Trendelenburg position, or a shock position. Soon, very soon, we're going to learn how to treat the patients for shock. It's very important. It's life-saving to treat patients for shock. So Trendelenburg, or shock position, how you treat a patient for shock is you provide them high concentration of oxygen, you keep them warm, and you elevate their legs 6 to 12 inches. If it's a trauma patient, then you have to protect the spine, but you elevate their legs. What this does is it uses the blood that's in the legs and it pulls back down towards the core to help increase the blood pressure. They're getting away from this now because they're saying what it does is it decreases venous return. It decreases the amount of blood flow back to the heart. Don't really want to do that, but we have to treat the patient for shock. And at a certain level, this is the way that you do it. So when I heard all that, I said, okay, I better check it. We went to the hospital the next day, and they had someone in Trendelenburg. So I thought, well, it ain't caught up with the hospital yet. So we'll still sort of use Trendelenburg, but keep in mind, just for FYI purposes, that this is on that bubble going away. Different things that they change. So Trendelenburg, or shock position. Right, any questions so far? Everybody good with the directional terms? So let's look at these systems for a second.